So we're starting to understand from the first unit on diagnostic tests for EBP is why this definition is used for a 1B study, a prospective blind comparison of the test and reference test in a consecutive series of patients from a relative clinic population. So the emphasis on this prospective cohort study and the consecutive groups of patients is because the heart of EBP is for the study designs and procedures to mirror or parallel the challenges you face in practice, and for the results to actually reflect what you will experience are you to adopt those particular diagnostic procedures. So given that, once we've decided that the test is valid, we have to then turn to interpreting the results. And so what are the results? So typically, diagnostic test results are used, analyzed in a contingency table like this, where you have the true reference standard positive, reference standard negative in the columns, and the diagnostic test results, the test you're interested in the rows. And so basically it works out something like this. So if the diagnostic test and the reference standard agree, you have a true positive result. If they agree on the negative side, you have a true negative result. And then basically the other opposite diagonals give you your false negatives and your false positives. And so it's important to realize that the first column, we have our first statistic is something called sensitivity, which is essentially the first column of this contingency table, and then specificity deals with the second column of this contingency table. And we can see that in the definition of sensitivity, we have the rate of false negative or mistakes, and then when we look at specificity, we have the rate of false positive mistakes. And so as the false negatives go down, sensitivity goes up. So basically sensitivity is good at ruling out. A high sensitivity means that the test is good at ruling out a disease, and that the opposite is true of specificity. So here we are looking at the false positive rate. So as the false positive rate goes down and specificity increases, that means that the test is good at ruling in the disease. And here these rules are kind of stated explicitly, as you can read those. So what we want to do, though, is motivate the different uses of a test and how it's interpreted. So essentially, if we go back to our ankle fracture example, and we note that in this kind of plot that each one of these values is a swelling number for a particular ankle sprain patient, and that basically the fracture number here is what the CT scan result is. So these people all really have a fracture, and these people all really do not have a fracture. What we can essentially do is draw different cutoffs for declaring a fracture based on the swelling. And so here in this example, we're drawing the cutoff on the red. We're saying, okay, 14 and below mean they don't have a fracture, and 14 and above mean they do have a fracture, and that's what these arrows indicate. Now, if we were to do that, what that would do is essentially mean that we had 2 false negatives here, and then 2 false positives here. So that seems pretty good. There's, out of the people we only have 2 in each. Okay, and so this would be our contingency table for that situation. So we basically chose the best cutoff that minimizes both the false negatives and false positive values. And so we would end up with, 10 here true positives using this 15 millimeter cutoff, and then we'd have 2 false positives here. So these are our mistakes. And that would essentially lead to a sensitivity of 83% and a specificity of 86% using that particular contingency table. Now, let's use the same exact data, only now let's draw the cutoffs in a different spot. So let's say we don't want to have any false negatives. In other words, we're going to bias our cutoff and our decision making toward having no mistakes, where we say somebody doesn't have a fracture but they really do. And this is kind of the situation we find ourselves in rehab. We really want to, if we don't want to do rehab on somebody that has a fracture, we're going to bias our cutoff to making to really where we don't want to make any false negatives, but we're going to have too many are going to amplify the false positives. And so basically by drawing the cutoff at 11, between 11 and 12, so we're saying everybody below 11 doesn't have a fracture and everybody above 12 or above has a fracture, and then we send those people for x-rays to confirm that. We're essentially going to assure that some people go to get x-rays that really don't need them. And so basically we pretty much more than doubled our false positive rate in this case. So by doing that, our contingency table now looks like this. So we have 0. We picked up all the fractures, so we have a 100% sensitivity, but we drove specificity down. We increased our false positive rate. And so this is a classic example of a screening test where we have a surrogate measure for fracture that we use to screen people, but we know ahead of time that what we're going to do by assuring that we have a false negative rate of 0, that the consequence or sacrifice we're making is that we're going to order more tests than we would otherwise. But in this case, it's necessary. We don't really want to have people go to rehab that have a fracture, so we're going to order a few too many radiographs, but the consequence is that we're assuring that we don't have anyone come that would need a that would have a fracture come to rehab. And so in essence what we're going to argue is that we've reduced the overall number of fractures by not having everybody get an x-ray, but only those people that we can't tell whether they have a fracture or not based on swelling. And so this would be a good application of a screening test. It benefits the patients by not unnecessarily requiring them to have an x-ray, and so it reduces the total number of x-rays. At the same time, it's prudent enough that we get the x-rays on the people that we know that the exam doesn't work for. Okay, so we could change the logic here, and we could say, well, let's say it's a flip situation where in essence we want it to be a confirmation test rather than a screening test. So we don't want there to be any false positives. And so the situation here would be is we draw the line up at between 17 and 18 millimeters. So we say that everybody above 18 or above has a fracture, everybody that's 17 or below doesn't have a fracture. So in this case we drive our false positives to 0, but now our false negative rate increases. So our contingency table looks like this. So if we look here, so the no fracture category, our false positives goes to 0, so that's 100%. And in this case our false negative rate now has increased. Okay, so this is a confirmation test where the benefit to the patient is really unknowing for sure that they have a fracture. So this would be an example. This would, for this particular example, it would never really apply. But if we pretended for a minute that we were using the swelling to indicate who needed surgery and who didn't, and we only wanted to do surgery on people who really had the problem, then we would want to emphasize the false positive rate going to 0 rather than the false negative. And so this would be an example, typical example that we face off with in surgery, say something like low back pain. Plenty of people have low back pain. Some of them may benefit from surgery. And so we really want to make sure that the people who go to surgery are really going to benefit. And so we only emphasize the fact that the positive tests that would indicate surgery is going to result in improvement, and the people who aren't going to benefit from surgery, we just let them stay in no man's land where they're not really, we don't really know their specific diagnosis that would have them go to surgery, so they really don't get the benefit of surgery, but they also don't get the possible negative consequences of incorrectly going to surgery when it really wouldn't help them. Okay, so that's the idea of a confirmation test. So basically, to kind of understand the differences between a screening and confirmation tests, we typically use something called the receiver-operator curve, and basically this is where we plot the sensitivity of test on the y, and then we plot 100 minus specificity on the x. And if we look at this, we can tell that essentially, basically a perfect test would then be this upper left-hand corner. So this upper left-hand corner is 100% sensitivity, so no false negatives, and 0 false positives, because essentially 100 minus specificity is the rate of false positives. And so this would be a perfect test. Now, we also know is that a diagonal across here is by chance, and basically flipping a coin will give you 50% of the test correct. So all of this space is really the value of the test in terms of chance, and then essentially this red area is the additional amount of improved information that the test gives you, and then this space, this blue space here, is all the false negatives and false positives. So it's kind of a graphical way of looking at an exam and how much it improved your clinical decision making. And so what we see here is in the confirmation test here, we see the 100% specificity represented, and then the 60% sensitivity that would be represented, and then here the screening test would be this upper right point where that's the 12-meter cutoff where we had 100% sensitivity and then about 40% specificity. So this is typically how we would look at how we draw different cutoffs for a test that we could plot in a contingency table like that. Now here's a more realistic example. In this particular example, we did the 5 times sit to stand and plotted the sensitivity and specificity of different times that it took the patient to perform a 5 times sit to stand. And then the authors of this study divided participants into less than 60 years old and older than 60 years old, and then looked at their overall, all the subjects at once, in terms of false positives and false negatives, in terms of predicting a fall, okay, in the future. And so if we look across these different ROC curves, it's kind of interesting. The 5 times sit to stand, which basically someone sits in a chair and we say ready, set, go. We time how long it takes them to perform 5 sit to stands, and then stop the watch, and then they get a time. And then we look ahead in time and see how well that predicts falling. And essentially for all of them, we can see here's our 50% point. And so chance is below that 50% point, and the amount of improvement in our guess of a faller is the red, and then the number of bad judgments or false negatives and false positives here in the blue. So essentially that's kind of for everybody together. But then if we look at the subgroups, people under 60 years old, well, geez, the accuracy of the 5 times sit to stand test is quite high really for people under 60 years old in terms of determining a faller and a non-faller. But for people over 60 years old, it was really not a very good predictor. And we can look here and see the cutoff values of 13%. So here they're looking, instead of looking for a screening test, they're looking for an optimal test. They're looking for this kind of corner point. Okay, and we can see that in terms of the entire group, the specificity and sensitivity values are pretty low. But for the people under 60, using a 13-second cutoff, it really gave pretty high sensitivity specificity values. And then again, for people over 60, it wasn't so good. Okay, so if we go back to one of the studies we were looking at that was looking at the clinical decision rule, developing the Ottawa ankle rules for people with with ankle fractures and using the weight bearing and then malleolar palpation and then foot palpation, so the malleolar zone and then this kind of other zone where you palpate different bony landmarks, and looking at those two in terms of predicting ankle fracture or not. This logistic regression analysis is used and then combined, and then once that's done, you input that into a contingency table. And so this is our sensitivity and specificity values for that particular data. And if we look here, here's the ankle fracture series with x-ray. Here's the Ottawa ankle rule result that said these people had a fracture. These people are tested yes for the fracture. These people tested no for a fracture. And so what we can see is that the foot and ankle series, they both led to lots of false positive rates, but they led to 0 false negative rates, and we can see that here. So the sensitivities are quite good. Here's our calculation of sensitivity and specificity from that. So the sensitivity is 100%, and the specificity is low. Okay, so essentially what this helped us do is this, we performed 300 over 400 fracture series that we didn't need to do, but it helped us eliminate 250. So it improved and it accurately picked up, 70 actual fractures, and then correctly predicted 258 fractures that actually didn't occur. So it really helped us in terms of our clinical decision making, and also we understood, though, even though it helped reduce the number of overall x-rays that we got, we still over-ordered x-rays by a factor of several. Okay, so that's a good example of how the Ottawa ankle rules performed, and so we know that we can depend on them, but we're also looking into the future for some tests that could help us reduce the false positive rates that's occurring with that method that we're using. And we also understand clinically that if we use this test, we're going to ask people to get x-rays that aren't really going to need them, but the alternative is that we could miss a fracture, so we send them anyway. Okay, so we want to move from sensitivity specificity to something called likelihood ratios, which are derived from sensitivity and specificity, but easier to use. And so this is going to help us in the question of how do we apply these results to our patients. And in essence, let's use a different example. So let's say we have a 67-year-old woman with low back pain and buttock pain, anterior hip and groin pain that worsen when the patient is walking. And we're going to look at the value of different questions we would use in the screening, or we would use in the subjective history that we gained from this particular patient. We want in particular to look at one of these questions related to sitting. And we're really going to apply these different results we've learned from the situations, the validity questions, and then what are the results in this application. So basically, we have two things to do in asking about how we apply these results to our patients. One is asking the question about pretest probability, and here we're going to combine clinical experience with prevalence. And so what we really want to clearly understand for this talk is prevalence, and then ask the question, okay, given prevalence, that's going to help us establish our pretest probability. How much should we allow the test to influence our post-test probability? And so what determines the pretest probability is just actually the prevalence of a disease. So basically, a spinal stenosis in an 18-year-old the prevalence is 0. And so basically, the likelihood that they have it despite a positive history would be 0, and therefore, the test would have to perform amazingly well in order to predict spinal stenosis in an 18-year-old. So this basically wouldn't apply to an 18-year-old, but would apply to an elderly person, because they have a rate of spinal stenosis of around 20-30%. And so that would be the kind of pretest probability that we would get there. So basically, you're combining pretest probabilities and test results, and so you need an estimate of pretest probability likelihood from prevalence, and then you're going to use your likelihood ratios to kind of look at how this applies to your thinking, and in order to do that, you're going to need something called a nomogram. Okay, so let's stick with our example. So we know we need a likelihood ratio, and then we need a nomogram, and we need a pretest probability. So for this situation, we're going to say that when we have an elderly patient with low back pain, given their history and prevalence, that we're going to give them a 50-50 pretest probability, and then we're going to work through the example with that pretest probability. So this is a table of different factors from the history here. sensitivity, specificity, positive and negative likelihood ratios. So we can see here's different things in the history that may or may not have known specificity and sensitivity with the condition of spinal stenosis. So we have symptoms become worse with walking. So walking as a symptom, its sensitivity is 71% and 30%. A good example, let's go to the one we'd like, some of the ones we'd like to use. So the absence of pain when seated. So this means that when they're up walking around, they have pain, but when they sit, the pain goes away. So we can see here the sensitivity is it's not good at ruling it out, but it's very good at ruling it in. That's the specificity, so spin. So the positive likelihood ratio is high, okay, and the negative likelihood ratio is really not that significant, okay. So that brings up the idea of how do we interpret a negative and positive likelihood ratio. So let's go back up to this first one, symptoms become worse with walking. So we can see the sensitivity and specificity are kind of moderate, so we're expecting the likelihood ratios to be also moderate because they're derived from those values. So basically, a positive and negative likelihood ratio that are not significant are going to be close to 1, and then their confidence intervals, which we see here, are going to include 1. So this is the positive is exactly 1, which means it doesn't really influence the post-test probabilities. And basically the interval between the two values here is going to exactly include 1. So it could be as low as 0.8 or as high as 1.3. So that means it really has no influence on our thinking. And similarly, a negative likelihood ratio, we want it to be as close to 0 as possible. But if it bridges 1, that also means it has no effect. And so essentially here we have it's very close to 1, and then the confidence interval varies around 1, and so that means it has no effect. But if we go down here to the absence of pain when seated, and we compare that to the sensitivity and specificity values, we can see that it indeed is much higher than 1, 6.6, and the confidence interval could be as low as 2.4 or as high as 18 times more likely to have the disease, and so it reflects this high specificity value. But now if we look at the ability to rule it out, which is reflected here in the sensitivity, we can see that essentially 0.58, so it is significant in reducing our probability of whether we think they do or don't have the pain. If they do continue to have pain when seated, well, that would be a negative test and would rule it out, right? So here essentially we have 0.43 to 0.77, so it doesn't include 1, so it's significant, but it doesn't go that close to 0, so we're wondering how much it should influence our post-test probability or our thinking about whether they do or don't have the disease. Okay, and we can go down for each one of them and do exactly the same process, and we can notice that really this ranks standing or walking as worse than sitting with regard to symptoms. If that's not true, that's the best question for ruling it out the problem, or gives them the strongest negative likelihood ratio. And the strongest positive likelihood ratios come from the absence of pain when seated, okay, and they're able to walk farther with the spine flexed versus extended. Those are the two keys. So we could kind of mix these history patterns up to kind of diagnose spinal stenosis, and that would be wise of us to weight the negative findings for the one question more, and then the positive findings for the other questions more in terms of ruling it in. Okay, so let's do an example of applying the nomogram. So remember, if we take the example of a pretest probability of 50%, what we do is put a mark on the nomogram and then mark the factor we're interested in. In this case, we're going to use the example of absence of pain on seating, and that's a positive finding. So if we put a mark here, then we draw a line connecting those two marks across this third line here, which is our post-test probability. It says the likelihood that they have spinal stenosis is almost 90%. So just that one finding alone gives you the diagnosis of spinal stenosis at a pretty high level. And so what we're learning is that basically if you go back and look at a series of questions you might ask somebody in a client interview, that as they kind of answer some of these, you should really weight some of the questions, answers to some of these questions higher than others because some of them shift your post-test probabilities where others of them not so much. And so here's an exercise for you to do. This is the accuracy statistics, positive and negative likelihood ratios for shoulder tests. And what would be a good exercise for you to do just to check yourself is to see if you apply these to the positive Hawken-Kennedy and a negative Hawken-Kennedy in terms of the test results to a nomogram and see what you come up with for post-test probabilities. And what you can do to get a nomogram is just go online and download one, or just kind of imagine what you would do and see if you agree with the next two slides that come up. Okay, and so here I would pause this now if you don't want to know the answer, or keep going if you want to see the answer before you try to apply it independently. So here's the probability of the disease with a positive Hawkins-Kennedy, so you can see that if you have a 50% pretest probability, it does really minor. It only moves your decision making by about 10% as if they rules in the disease, so it's really not very good at ruling it in. But if you apply the negative likelihood ratio, it basically moves the post-test probability for a negative test to under 30, so it moves the post-test probability over 25 or 30%. So it's much better at ruling out the disease than it is ruling it in. Okay, and then the final thing you want to consider when you're looking at the feasibility or application of these tests is whether they're practical to do in a clinical setting. So it's both the likelihood ratios and the interaction with you and your patients that determine whether you actually choose the disease. So overall, here's some lessons learned. Tests can be good at ruling something in and terrible at ruling something out, and vice versa. Tests can be designed to either rule something in or out on purpose. And for tests that are continuous, they have basically like a time variable or something that's a continuous measure. You can have a continuum that may or may not be present. So sometimes you can use extreme high values or extreme low values to make judgments. And that good example, that's the timed up and go test. And then applying the test to patients requires an appreciation of the mistakes, the false negatives and false positives that are likely. And ultimately, likelihood ratios and post-test probabilities give you a very clear definition of how you should think about these tests in terms of influencing your thinking clinically. Well, that was a lot of work, and I appreciate your time.